Okay.
We are good to go. Welcome. Glad to be back with everybody today, and especially glad to be back with Glenn, our expert epidemiologist extraordinaire. How about all of those E's in one sentence? As we know, Glenn Grossman is an epidemiologist with over 20 years of experience in just this year. No, I'm just kidding. 20 years of experience plus the year 2020. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology projects with Medicare, Medicaid, Veterans Health Administration, the Military Health Service, the CDC, and other programs in the United States and outside the United States. He currently is Senior Director of Outcomes Research and Epidemiology at Novartis, but all views expressed today are his own. So with that, I hand it over to Glenn Grossman. And as usual, we start off with sort of a state of our country, state of the world. Where are we? How are we doing?
Great. Thanks, Beck. All right, let me share my screen. All right, share screen. And I'm going to share this. All right, so first, good news. So usually I've been ending with good news and beginning with bad news because of the rise in COVID. But there's actually good news now. So over the last couple of weeks, we saw what could have been noise, but it looks like definitely a real signal now where we're flattening the curve. Now, the problem is we're at a much higher level than where we were back in diagnosed cases earlier in the year. And so the good thing is we've taken our feet off of the gas pedal. And so now at least we're no longer accelerating. We're no longer having exponential growth. Right now, the R is around 1 around the country, a little bit less. But on average around the country, you can see that this flattening means that the R is roughly 1. But this is good news that it's not out of control anymore. We're not rapidly going up. Well, let me rephrase that. It is out of control because these numbers mean it is not under control, but it is not growing exponentially, and that itself is good news. So we need to take the good news where we can. But having said that, so now let's focus on this part, that it's still out of control. These are the number of new cases diagnosed per day. And so this is quite a lot. You see that some days we're still hitting a lot. I have a better screen of this. So that was diagnosed. I prefer to look at it this way sometimes. Last week, we had over 465,000 new cases. This week, there are 437,000 roughly new diagnosed COVID-19 cases. And so we've gone down some, and that is good news. In terms of the total number of likely infected, you see that we've definitely exceeded where we were on it in terms of daily new infections. This is, again, this 418,000 estimate. It might even be a little bit higher. This is the estimated number of infections. And then the one I was showing you before was the number of diagnosed infections. And that's why this one is so much less. And so, yeah, don't look past here because I don't trust this model for its predictive strength for much of it, but I do like its approach to predicting the total infections. So anyways, we are going down a little bit. This is good news. I wanted to look at a high level. So we have up here the total number of tests. We have the testing has been going down a little bit, but that does not explain the drop in cases. We do need to be doing a better job of testing because testing helps us to reduce the spread, because once people know they have COVID, then they stay home and it makes them less likely to infect others. And then through contact tracing, we can go and we can identify other people and test them and just stop the outbreak. But this is real in terms of the decrease that we were seeing. currently hospitalized has been going down some as well. The deaths are continuing to rise because, as you recall, there is a delay between the cases, the hospitalization, and then the deaths. The one other thing that's not represented here is the age distribution. So although the cases are going down, it's likely the case, although we don't have data right now to support this, but I would guess that right now it's likely the case that a lot more transmission is within the household now, whereas a few weeks ago it was people going out to bars and going out to parties and stuff, and that's how it was spread. Now people are much more precautious, and so so that means much of the spread, they're probably staying home more, and now there's probably more spread within the household. And the problem is that within the household, some people might have more risk, and so that would not surprise me if we see the decrease in hospitalization actually is not as sharp as it was earlier in the year. And then we're going to continue to see an increase in deaths for a little while, I think. We'll see. All right. What's driving this? So there are a couple things driving this. Let me show you. Let me just stop sharing for 1 second. All right, now where are we? All right, let me share my screen again. All right, so here's one website that I like. I don't know that we've looked at it much before. And so I'm gonna turn highlight to none. And now what you can see here is that there were basically 3 states that were driving the big uptake, the big number of cases over the last few weeks. And those cases were Florida, California, and Texas. And so there were some others when you look at a per capita basis that were higher. But in terms of the total volume in the US, you can see that these are really driving the whole change in the United States. And so you can see that Florida, it's hard to see, it's cut off. I tried to change this a little earlier, but I was having difficulty. So Florida went up to here somewhere and then came back down. Texas also went quite high and then came back down. It's still quite high, but it's on a downward trajectory. And California hit this sort of plateau and has sort of continued on this plateau for a while. So between the 3 states that are really driving most of the cases, you see that there is true flattening. And so this is good news. Some of these other states are continuing to see an increase. So Tennessee is on an upward bend. Arizona also has been coming down. There's a better way of looking. So this is a little bit weird, but let me go to x-axis last 8 weeks, and then I'm going to not highlight, and then I'm going to go here. So now if we look, so now this is the same thing we were looking at before, but per capita. So whereas before it was the total number of cases, just total adding them up, here it's reported normalized by the population. So if a state is smaller like Arizona, then it's gonna appear higher here because it's relative to the size of the state that it's reported. So you see that Arizona was crazy out of control a month and plus ago, but then now it's been getting it back under control. And other states too, Florida, you see it's the same story that I just said before, but now other states are also represented more closely here. So Mississippi continues to be on an upward trend. There's a little bit of noise there. Louisiana was going up. It looks like it's coming down a little bit. But you see that now when on a normalized basis, there's actually a lot more growth. If you go back, I'm going to go back, instead of 8 weeks, I'm going to go back 12 weeks. So you see that before, when we started going down and we started getting to this minimum that we had around 55, 60 days ago, from there, we've increased a lot and we're seeing a lot more state involvement in terms of the spread. So definitely if I were to characterize what the spread looks like now, there's a lot more states that are involved. And in fact, if we look just at some of the dashboards I like to look at, you see that there's a much more widespread, many more states involved. This one I like to look at as well. Right now on this one, some weeks New Jersey has been green. New Jersey is shifting a little bit. I know some of the people on the call here in New Jersey. That's because there have been a few more, not a few, yeah, I mean, dozens more. Maybe I think that if I recall the absolute number, has gone up a little bit, but we're not talking about a ton. The big problem here is that the contact tracing has really diminished. We were at 100% before, and now it's gone down. I talked to some people in the Department of Public Health in New Jersey, and they expect another outbreak happening within weeks. In fact, they've told their staff to take their vacations now, because it's going to be coming again probably. Hopefully, if we just hired some more people, some more contact tracers, and did some more, ensure more people wore masks, we wouldn't be going through this again. But I mean, it's going to be hard either way. As the winter comes, we know that the seasons may have a big difference. And as we go back to opening up the schools in some places, as we hit fall and winter, a lot of our activities where we're able to do them comfortably outside and then have the physically distancing outside, and we have the reduced exposure, a lot of it's going to go back inside, and that's really going to increase the R value, this reproductive rate. Yes. Becky, I don't know if you could read Debbie's, what Debbie just said.
Yeah, sure. So what Debbie's asking is, are you referencing an outbreak before the flu season perhaps, or concurrently?
I mean, so terming it an outbreak, this is technically an outbreak. We still have an outbreak across the country. It's still an outbreak. It's an outbreak in all the states. Whether the volume of new cases goes up, yeah, I mean, it's already going up slightly. I don't think that we're going to get into a situation before early fall where we're going to look like some of these other red states. But we are in terms of some of our caseload going up. We're just not keeping up with it. When we look at the test and trace dashboard, so right now, the number of tracers, if you can see in the middle of the screen, I can't point to it easily. If you see in the middle of the screen, it says New Jersey. Towards the bottom, it says the target number of contact tracers is 5 to 15 for each state. 5 to 15 contact tracers per positive test result. So for every positive test result, there should be at least 5 people available to go and reach out to all the people who might have been exposed to the person, try to identify the person who got that person sick so that they can go and get them tested and make sure that those people are traced. That requires a whole team of people actively involved. New Jersey is only down to 1.7, 1.8 tracers per positive test. So that's below what we need to be. We were far higher before. We had it really in control in a few weeks ago, but we're not keeping up, and our contact, both our testing and our contact tracing are now diminished. Ultimately, the test results, in order for it to be worthwhile, need to be returned within 24 hours, maximum 48 hours. And I've heard so many stories in New Jersey and other parts of the country for sure, where the tests are taking far longer than 24 hours to come back. And you can't do effective contact tracing if you don't have any test results back that quickly. So this is where we're failing. It's just not, we don't have the logistics down yet.
Glenn, just a kind of a follow-up question to that. So New Jersey is being impacted because across the country, these major operations are being inundated with tests, right? So we're feeling sort of the ripple effect of that from these labs. Is that right? Because of what's happening around the country?
I mean, so I don't think that that's essentially the case, because a lot of the testing would be done locally rather than shipped outside of the state. There could be constraints in some of the fluids and stuff that are required to do the tests. I think it's just the sheer volume of tests are overloading the capacity. It could be that some other local neighboring states are leveraging some of our testing capabilities for their outbreaks because they have more positive tests. I don't know if that's the case. I don't know because I mean, one hypothesis could be that people in other states are coming to New Jersey if they think we have more capacity and they want to get their tests done here. I don't know if that's the case or not. The other thing, one of the reasons that our caseload is going up is because a ton of people are traveling through New Jersey. They're stopping at the rest stops, they're stopping at the diners and whatnot, and visiting friends in New Jersey. And so they're traveling from all these other states. And a lot of our new COVID is coming in from other states. And there's not an easy way for our contact tracers to figure that stuff out, because they're new infections. It's not like you can contact trace and then figure out where in New Jersey someone got it. If it was from a friend who visited from the weekend from DC or from Pennsylvania, which is a darker color, then guess what? Our caseload is increasing, and it's very hard to keep that under control. That's why there's a big difference between a federal lockdown, so the whole country at once, versus a state. Because with states, you get into trouble like this. There's no way, unless we were to close our borders in New Jersey to other states that were at higher risk, there's no way to keep that under control.
Growing up on the I-95 corridor, I mean, we can both attest that we do have excellent diners and
Indeed,
other
indeed we do.
that would encourage folks to want to travel through our beautiful garden state. So I agree with that. I just hope that this rate that's diminished is not because of lack of funding, and I hope that we see increased funding to hire more and more tracers, and that you're not seeing decreased funding.
Yep. I think there are funding constraints, but it's more than just that. There's definitely logistical constraints because people have to be hired and trained, and all sorts of things are going on. Yeah.
All right. So we've had a shift in the reporting of data recently. And one of the things I love most about being together every week is that you really distill so much data down to its essence, but not just that, it's data that you trust so that we trust what you're reporting to us. And there's a lot of data out there. And now that the Department of Health and Human Services took control of this COVID data, can we trust what we're seeing coming out? You know, it felt very reliable up until a few weeks ago. What's your sense?
Yeah, that's a really, really good question. So the CDC, the Center for Disease Control, has historically been responsible for surveillance. So for identifying the disease, for diagnosing it, for tracking it, for dealing with outbreaks, surveillance, and to sort of testing and identifying this stuff, testing and tracing. The surveillance aspect has been a core component of the CDC. So it was a shock for a lot of us when it was shifted right in the middle of the epidemic to a private company with Health and Human Services. In fact, there was a meme on Facebook, and I'm going to open up this tab in particular, which I think is consistent with what people were talking about. If you can look here, on Facebook, there is this idea that the cases were going up, and then they sort of flattened at exactly the time that the data shifted, that we heard in the news that the data was shifting to Health and Human Services. And so a lot of people found this highly suspicious. But I'm here to assuage your fears. This is not actually a real thing. The data that was moved to the Health and Human Services was hospital data only. It wasn't testing data. And so this data that we're looking at here are the cases, the confirmed cases from the tests. So this is what's reported by all the states and the local levels in terms of what's reported and then aggregated. And so if you recall what I just mentioned a few minutes ago, in fact, this graph probably looks somewhat familiar. When it's looked at a high level, it might seem suspicious. But when you look at it over here where we just were, let me go back up to this one. Here you can see that these 3 states are really representing all of that flattening. And that's all because of Florida, Texas, and California. Florida and Texas have been coming down, and California has been staying roughly the same. And together, that gives you this apparent flattening and lowering down. It just happened to coincide with Health and Human Services taking it over, but I don't feel that this is actually a Health and Human Services issue. I'm still surprised and alert to the fact that they took it over, and I don't understand why they did it or what that means or what the access is. I think there's still worries in terms of getting some of the hospital data and trusting some of that. But in terms of this meme, it's not true. The cases are as I described them. If there is an issue in terms of data, then it would mean that Florida and Texas and California are the ones that are misreporting the data. So it's not a Health and Human Services issue. It's data being reported and tested at the state level. Having said that, there is something that's great. So Health and Human Services is required now that more data be required, be collected and be reported. And so they're about to increase it to ensure that around the country, we have better information about age, race and ethnicity, sex, and then also whether the patient has been hospitalized, whether they're a healthcare worker, and whether they're in a long-term facility, like a nursing home or long-term care facility. So this is going to be really great. It's going to help us to manage it a little bit better. I'm very happy about this new guidance. So this is good.
That's good to know. I wasn't expecting you to say that. I was expecting you to be suspicious of that.
I'm an honest broker. My intention is not to scare you. I just want to tell you the way it is, and this is the way it is.
That's why we come back and like to be with you week after week, because we do appreciate that. So that is very encouraging. I know many of us were concerned about that. Speaking of concerns, Marla had a great question earlier. Marla, if you'd like, I can unmute you to ask your great question about face shields and Dr. Fauci. Let's see. There you are.
Okay. Hi there. So my question is, Dr. Fauci came out this week talking about the fact that recommending the use of goggles or a face shield. Right. So my question to you is, how likely is it for one to be infected through their eyes, and how important it is for us to wear a face shield or goggles when we go public places?
Yeah, those are really important questions, and I don't have good answers. I don't think anyone has good answers yet. So right now, I think his recommendation was mostly because of the uncertainty of it, rather than any specific reason. If you recall, there are 3 ways that this virus can be transmitted. The first way is by hand-to-hand, is by contact. So if someone touches this, is coughing or sneezing, they touch their face, and then they touch other people, and it's communicated by touch, then that's one way. The second way is if there's droplets, if people cough or just in their breath alone, even without coughing, there could be small droplets that come out. Typically, the droplets only last in the air because they're heavy enough. They only go maybe 3 feet, possibly a small percentage of them go as far as 6 feet, but most of the droplets will fall far before them. And then the third way are these aerosols, which are really, really tiny, and they can go very long distances, and they can float in the air and stay in the air for many, many minutes at a time, for long periods of time. They can travel across the room, especially if it's not very well ventilated. They can stay around in the air for a while. And so with these 3 types, these 3 routes of exposure, if someone touches someone who has been infected and then they touch their face, neither the mask nor the face shield is going to really help to protect that, because then they're their own worst enemy in terms of the touching. And that's why making sure we keep our hands clean is really good for that. The second thing for the droplets, so the masks help a tremendous amount for the droplets, and the face shields probably help some for the droplets too. Now, where you wear them would make a huge difference. So for instance, if we're outdoors and we're already remaining 6 feet away from people, then a face shield is really not going to do very much at all. And so we don't really have to worry. If we're indoors and we're worried about droplets, then that would be effective if, say, we're within 3 feet of someone. So for instance, I went to the dentist recently, and face shields are now mandatory there. They're all, I don't know if technically mandatory, but every dentist is doing it because you don't want to have any risk of exposure in your eyes. And so things like that, you do have to worry about it, like depending on how close you are with someone. Normally, we need to keep as far away as we can from someone if there's no reason to be closer. So we should not, especially for people who might be at higher risk, don't believe that if you put a mask on or a face shield, that it's some kind of protective shield that you can suddenly become invincible and go out and not worry about infection. Because that third route that we talked about, the aerosols, which we're quite confident are a route of infection for this virus, the aerosols can go through the mask, and they can also go through the face shields, because you see the face shield doesn't fully cover the face. So yes, it does protect some depending on where you're going, but the aerosol part, it's not going to make a huge difference with. So I think that there's still a lot of uncertainty in terms of the question of how much of exposure is accounted for by the in the eye exposure. So, I mean, if you look at this graph I just showed you just a few minutes ago, in terms of those sharp declines that we've been seeing in Florida and in Texas, much of that is that there's universal mask requirements now for those states. And then the other thing is we've been seeing just a gradual decrease due to it's not a universal lockdown like we saw, back in March and April, but there's a lot more constraints in terms of what people can do. People can't go to the gyms anymore. The restaurants, the indoor eating has been constrained. And so there really have been more policy changes over the last few weeks that we can see have had a tremendous impact. Those things are way more important than the face shields. So if I had a choice of what I would do if I wanted to limit my susceptibility, the number one thing you could do is go outdoors instead of indoors. The number two thing is physically distance. So every 6 feet away you get, the better it is. I think that if I remember the stats from a few weeks ago, I think when we looked at it, if you're 3 feet away, then you reduce the likelihood of getting infected by around 80%. And then for every additional 3 feet, it reduces it another roughly half of what that number was. So it's close to 90% at 6 feet away. And as you go further and further away, then it reduces it even further, the likelihood of getting infected. The face masks themselves, I don't know that it provides a tremendous amount of increased protection. Probably more indoors than outdoors, but like I said, and so the third thing, I said the first two, being outdoors, physically distancing, and then third is the face mask. And between those three, that it's, I don't know, the incremental value of the face shield on top, I don't think is quite as high, but there probably is some based on the droplets. All right, so that was quite a lot of information.
Yeah, no, that was helpful. Debbie actually has a follow-up question about kids and masks. So here, Debbie, I'm unmuting you. We're asking you to unmute.
Hey, Glenn.
Hey.
I was wondering if we think that since kids in school are going to be next to each other, not outdoors, and wearing face masks, if this is something that we should be talking about in regular conversation with our schools and amongst each other, because I've never even thought about getting a shield for my kids. But
yeah, I think that with the physically as long as people are staying physically distanced, then we don't have to worry a lot about the need for face shields at this point. That's where my position is right now, just based on what I've been looking at. In the coming weeks, maybe that'll change as we hear more information. But as far as I can tell, there isn't tremendous new information that's been released that suddenly face shields are this big requirement. Indoors, the kids will need to physically distance from them among the other students. And then, I mean, if they're already 3 feet, 6 feet away from each other, the incremental value of the face shields, I don't think it's going to be super, super huge.
How about goggles or glasses? That feels a little less sort of, shall we say, in your face. I'm playing out a role today, aren't I? But so, I mean, might that provide value, like even glasses for kids who don't wear glasses normally, but with just clear lenses, non-prescription lenses, let's say. Might that add just another layer of protection or not really?
Well, you're talking about vanity glasses, but before that, so goggles actually have two advantages. Because if you're near a pool, you can jump in and then you don't have to put your goggles on, but most people wouldn't think about that advantage. The main advantage of goggles would be that it covers your eye completely, whereas glasses don't cover your eye completely. And so it goes back to this idea, if COVID is aerosolized, then the space in your glasses the aerosol is just going to go right through without hearing. And so it doesn't make a huge difference. If you're worried about splatter in terms of these small droplets, then yeah, having glasses might make a difference. I don't believe it's a major incremental value. I think that the mask and the physically distancing that are the biggest impacts. The glasses might have an incremental benefit, but it's probably not super huge.
All right. Well, thanks for clearing that up for us. Just a reminder, if anyone in the audience has questions, you can send them directly to me, and I'm kind of queuing everybody up. So I think think about those questions and send them my way. Next, Sandy, I will unmute you. I am looking for you.
I
Oh,
did.
you did it. Okay, so Sandy has a question about how deaths are being reported, Glenn. So,
Glenn, I hate to be questioning all the reports that we get, but in Florida with our dashboard inconsistencies and our governor and whatever, I'm always a little suspect. So are the deaths that are being reported from COVID, that if somebody dies of a heart attack or complications of diabetes or kidney disease or whatever, are they being reported as COVID deaths, or are they being reported as lung problems or pneumonia or whatever it might be?
Yeah, give me 1 second to open that up.
Sure.
All right, there I am. All right, so we looked at this website last week, excess deaths. Let me go to Florida in particular. All right, so the first question here is excess deaths with COVID. Now let me update the dashboard, go from United States to Florida.
You missed. Oh.
Oh, whoop, I'm just going too fast. Florida comes earlier. Yeah, I was looking at other things going on at the same time. So now I apologize, this is a little bit hard to see, but so now you can see this is 5,000, 4,000. We're looking here, May, the most recent week of data is a week later than what we had last week. So July 18th, last week we were looking at July 11th. And so if you look here, if I can just talk, so the blue are deaths that are reported as COVID. Whoops, I can't use the mouse. Blue is what's reported as COVID. Green is what's reported as just a regular death in terms of other things and not as COVID. And if you see, go to the left side of the screen. I'm sorry, every time I move the mouse. Oh, I can do it. So if you look over here, no, I can't go down. If you look under the orange line, all that white space, then that shows you what you would expect in a normal year typically. There should be a lot of white space. The orange line is sort of like the statistically significant threshold in which if it's above that consistently, then you know there's some sort of outbreak that's going on. And so, but it tends to be very conservative. This orange numbers are much more conservative. And so if we look here at the expected number for this month, the expected number was 3,870. The threshold, this orange value, in the most recent week of data, again, this was the 18th, was 4,000, and the actual number of reported cases was 4,700. So almost 1,000 deaths more, not quite 1,000 deaths more than predicted. But if you come here, then you'll see, so the predicted number was 3,870. The green, which is, these are the number of cases, or rather the number of deaths that were not reported as COVID, there were 4,090 of these. And so the 4,090 you see is higher than the 3,870. So there still is this gap of an increase in deaths over what's expected. If you look at what the numbers are, like what's actually being reported as the source of death, then let's go here. There is variation from state to state and place to place that I've noticed. But if you look at, let's go to this one. So if we go back to Florida, so you see that there was, this is a little bit hard to see because this is from the beginning of the outbreak. Let's go over here instead to total number. All right, so here's Florida. Yeah, I like this view better. So if you look at what people are actually dying from, a lot of people are actually dying from cerebrovascular disease. So that's stroke is what a lot of the people are being reported at. We know that COVID is a clotting disease. And so in addition to, and this is what we saw previously in other states, New York City, if you recall, we looked at that last week. It was being, a lot of cardiac arrest was being recorded. And so that was showed up as a spike here. Here we're seeing a lot more stroke in Florida as what's being recorded as all these excess deaths. We know that there's not nearly so many strokes that you'd expect in Florida. You expect strokes, it's an older population, but not nearly so many. So these are the excess number of people who died of strokes since February in Florida. And so it makes up quite a lot of people. there's this other number here. These are Alzheimer's disease. And to tell you the truth, I don't really understand how this is interpreted because it does vary a lot. If someone has Alzheimer's disease, sometimes people can die from Alzheimer's in the sense that just the neurologic change over time. But in terms of the death, sometimes someone could have Alzheimer's, but then also have a heart attack or also have one of these other things. And depending on what the cause of death is put on their death certificate, I think it varies from place to place. So it's a little bit hard to interpret Alzheimer's disease. We do know that, yeah, go ahead.
I'm sorry, but if somebody has Alzheimer's and has a heart attack, but has COVID and might not have died from Alzheimer's yet, or the heart attack might not have been triggered, then what do they call it?
So that's the thing, is that all of these are likely to be COVID related. Every single one of these, because these are all excess deaths. Every year people die from Alzheimer's, but there are far more people that are apparently dying from Alzheimer's since February than you would expect. And so they're being listed as Alzheimer's, even though these are almost certainly COVID.
Okay, thank you.
And it might be a mild case. It's not necessarily like end stage Alzheimer's that you would expect. For a lot of these people, it might just be very mild dementia, but then they get COVID and the state just reports it as dementia.
But is that dependent on the state and their politics?
It's totally dependent on the state and the politics. And that's why, going back again to this, there's this, it's a political question. It's become, in terms of whether we call it COVID death or not. And if you see here, there's a lot of deaths that are occurring that are called that are not called COVID, even though we can see that they're excess deaths. And there's no other way to explain it except that it's COVID, because there's not another outbreak going on at the same time that we're not aware of. It's COVID.
All right. Thank you, Glenn.
You're welcome.
Wow. So glad you're breaking down these statistics for us because it's not really what it seems to be in many ways, right? And that's really helpful. So thank you, Sandy. Great question.
And Becky, so we talked a little bit more about this. I know you weren't able to come, but last week I did a deep dive on some of these questions about the reporting of the fatalities and the deaths by the cause of death, and looking at some different areas and answering some questions. So if anyone has additional questions, we answered a bunch of different questions. So you can go back and look at the YouTube from last week, and then you can anyone who wasn't able to come last week could take a look. Not anything about you, Becky, but just anyone else who might be watching this right now.
I'm sorry.
No, it's all good.
Yeah, it's a merit, but I am glad to be back. So tell us more, Glenn, about your prediction, or can we predict now that we're months into this thing, who will get a severe response and who might just have a mild response? Do we know anything else?
So right now we don't, but we have a way. The good news is that we found a way to predict who will have a severe and mild response. So it would not surprise me if in the coming weeks, scientists develop a score so that if someone's infected, then we can just sort of take their blood, do a test on their immune system, and then score them for the likelihood of having a mild response or severe response. And that's because of this one study. There's other things that we've been talking about just generally at a high level epidemiologically about the risk of having a severe response based on age and ethnicity and comorbidities and some of these other things that we talked about. But what's unique about this new study that I found really intriguing is they found these big differences in immune responses. So among people who first were hospitalized, let me show you what these are. So all of these are different aspects of the immune system. These are immunoglobulins. They're all different kinds of molecules and components of the immune system. And what you'll notice here is that they took these blood samples from everyone as they first got into the hospital, and they took samples from their blood. And what you'll notice is that the people who ultimately had the most severe illness and who ultimately died, they had really, really small numbers of these immunocomponents. And the people who did really well and recovered had high levels of the same things. And so you can sort of look at this here, and this was in the spike protein. Also, just the opposite in the nucleocapsid, which is a different part of the virus, you'll see that there's small parts here in the people who recovered and large parts here in the people who ultimately had the severest disease and ultimately died. And so that means that simply by taking a blood test, as soon as someone is infected even, or even if they require hospitalization, we could develop a pretty strong, robust scoring system to identify who's going to have a severe response and who will have them out. So I really hope that someone develops the scoring system soon and rolls it out, but it would not surprise me at all to see it within another few weeks because it's such an important finding. So this gives us really good guidance. These are averages, these are not specific people, but even still, that it's so pronounced, the variation that we're seeing, that it's good news that it enables us, because then you can treat people differently. If you know that someone who's hospitalized is very, very likely to recover, then you could treat them differently. Maybe they don't require quite as much attention as someone who's destined to become a more severe case and have to be at much, much higher risk. So so this is good news, I think.
That's really exciting. Who's doing this research? Where is this coming out of?
Oh, that's a good question. I don't know. It was published here.
There, I know you always have your source.
So the references are here. If anyone who wants wants more details about this study, just either Google it. Here's the name of the title up here, or else look at the DOI, and then that'll bring you to the study.
That's really exciting news. That's really a very exciting development.
I'm glad I could be the bearer of so much good news tonight.
You really are, Glenn. I mean, keep it coming. So while we're on talking at the cellular level, can we talk a little bit more about T cells? So a question has come in, are some people protected even if they don't have antibodies? Will this lower the herd immunity threshold?
Yes, so if you recall, there's basically two ways there's multiple ways that the body can prevent or fight a virus infection. But the two adaptive immune responses that we've been looking at are antibodies and T cells. Now, if you recall from previous weeks, the antibody response, the way that works is that attacks the virus itself. So it finds different things that are sticking out of the virus. And so typically when we're talking about antibodies, we call them antigens. But so in this case, we've been talking about the spike protein that sits on top, and that's why it's called a coronavirus, because all these spike proteins make it look like a crown. And so there's actually lots of different things that make up the virus. And so an antibody can attach to the spike protein or any of the other possible proteins in there. But the antibodies in general are attacking the virus itself. In contrast, the T cells, you can see that like a picture like this, the T cells don't infect the virus. The T cells find cells that are infected with the virus. And before the cell can start to release the virus out into the bloodstream that it's rapidly producing inside, the T cell comes and eats the cell itself and destroys the cell. And so therefore, it's not even attacking the virus directly, it's attacking the cell that's already doomed, and it just takes it out, and then it can't release all the virus into the system. So both of those are important. We've been doing antibody tests. There does not exist an easy T cell test that we can do the same way that we do antibody tests. So we don't have a good way of knowing the number of people that have T cell responses. This study has been referenced quite a lot, and I talked about it a couple months ago. This was back in May. I talked about it shortly after that. And there have been some studies since then. The key ones that have been looking at how much T cell activity is there among people who have never even been exposed to COVID. So for instance, there was this one team that took stored blood samples from 2015 to 2018 before COVID-19 was even a thing. And what they found was that there was a lot of response in that blood to the T cells when they tested them. So we do have lab tests that you can do for T cells when you're just doing a few. When I said earlier that we don't have a test like an antibody test, we don't have a commercially available widespread test where you can give it to to thousands of people and then get a result back within 24 hours. This is a clinical lab experiment that was done where on that level you can look at T cells and you can see if they exist. And so they analyzed the blood and they found that 34% had these T cells that recognize SARS-CoV-2, and this is because of cross reactivity. And so there's two things. So one, this could be caused by other coronaviruses in circulation and things like that cause the cross reactivity. But the biggest thing is that we don't know if it actually is protective immunity that it's doing. So it might be sort of have this cross reactivity where it's identifying the T cells, but we don't know what it actually means. And without an antibody response, we don't know if a T cell response is strong enough to fight off the virus. So for instance, what if someone gets infected with coronavirus, the T cell response might be strong enough to make the symptoms very mild or even asymptomatic, but it might not be strong enough to prevent the person from being contagious and spreading it to other people. So that's one of the distinctions, is that with an antibody, you can have what's called, and we've talked about this previously, neutralizing antibodies. And those attack the virus directly and go on top of the spike proteins and protect it from actually infecting any further cells or infecting anyone else. The T cells don't do that. And so you might not actually have, you won't have certainly not have a neutralizing antibody if you have a T cell response. And so the person who has a T cell response might still be able to infect others. So we don't know what this means for herd immunity, but what we do know is that, let me just talk about this briefly, this idea of herd immunity. Let's just jump into that again. So just as a refresher, there are three things that are used to calculate the herd immunity threshold. I haven't done this calculation before or shared it here, but I can go through it just if there's interest. The first is R0, the reproductive rate. The difference between the original R, so before we even knew what was going on, how much it was spreading in the community, versus the current R. Right now the R is very low because everyone's wearing masks outside, we're physically distancing, we're taking precautions, we're not doing the activities that we were doing a year ago because of COVID. And so as a result, our R value, our effective R, has gone way down. What's used to calculate herd immunity is that original R before we changed our lives. Because herd immunity, once we reopen our lives again, then that original R is going to go right back up to where it was originally. So we need to calculate the herd immunity based on the original R. And the problem is this R is determined by three things. One thing is the virus attribute. So for instance, if it's a respiratory virus, it has a different R than other types of viruses because you can breathe it out or cough or sneeze. The second type is the patient characteristics. And so for instance, some people might, for whatever reason, we don't really know yet, just in their breath alone, it aerosolizes quite a lot more. And so some people might infect 20 or 30 other people, these super spreaders. That's all a patient characteristic rather than a virus characteristic. The third is social or cultural norms or local things. So for instance, in New York City, where a lot of people were taking the subway and were very close with each other, near each other, then it's much, much easier for the virus to spread. Whereas in the South, where things might be more rural and more spread apart, then maybe it might be harder for the virus to spread if people spend less time in like subways together and really close quarters. And so these three things together are what contribute to R. When we go back here, before I get into these other things, the first thing is the herd immunity threshold, and this only uses R to calculate it. And so basically, it's 1 minus 1 divided by that original R value. Now, we were talking about the original R being between 2 and 3, and this is R0. I like to think of it as R times 0. And so the original R was 2. And so if the original R was 2, then the herd immunity threshold would be 50%. And again, that would mean that once you hit approximately 50% of the population being infected, then they would sort of provide sort of this de facto barrier, and then it would be harder for other people. There'd be a little bit of overreach where you'd still have a little bit more infection, but it wouldn't be this exponential growth that you would have seen previously. If R is 3, then the herd immunity threshold would go up to 66%. And R of 5 would go up to 80%, and R of 10 would go up to 90%. The reason I say this is that in New York City, the R naught was closer to 5 is our best estimate. And so that means that the herd immunity required, or the herd immunity threshold in New York City would probably be closer to 80%, whereas some other states where the R was closer to 2, the herd immunity threshold would be closer to 50%. The question here is the T cell question now. Well, if some percentage of the population is not susceptible, then that lowers the number here, because then you don't have to worry about them getting infected. So for instance, this assumes that 100% of the population is susceptible. So instead, this herd immunity threshold would be a percentage of only the susceptible population. So say 50% of the population was previously exposed and or let's say had T cell immunity from decades ago or however long it lasts, and for this new infection, only 50% were susceptible. Then if R naught was 2, then the herd immunity threshold would be 50% of the 50%. So the herd immunity would be 25% of people would need to get infected in order to have this diminished response. So this percentage is of the susceptible population. Like I said, so I have not said this, what I'm about to say. So here is not the concern. Here is my, what I've been witnessing. So this idea that there's so much T cell protection out there is a little bit, I don't believe it in terms of the way that we're interpreting it. And here's why. So it might exist, but I don't believe it's going to prevent the spread is my point. And here's why. We've seen evidence over the last month, or couple of months at this point, that there are areas that have exceeded 70 or 80% with an antibody response. So again, and the ones we've looked at previously, I should have brought it down here. So last week we talked about Peru. Let me see if I can pull it up quickly. Yeah, here it is, Peru. I apologize, this was Google Translate, and so that's why it doesn't look very good on the screen. This was the English version, but what this found was that in one small town in Peru, this was antibody test screening test was done between July 13th and 18th, and they found around 71% of the people and this was a well-designed study. It was a randomized, stratified sample design. It was well designed. 71% were antibody positive. If that were the case, then either the 30% that were previously exposed and had a T cell response meant that everyone who did not have a T cell response was infected and had an antibody response, which would be bad if everyone was infected who did not already have a T cell response, because that would mean that the spread was far, far faster than we thought, and that there's no herd immunity among those who are still susceptible. Or another reason that it could be what we're seeing is that there is no T cell protection. And what I was mentioning a little bit earlier is that the T cell might just reduce the severity of the disease, but that it can still be spread. Or, I mean, there's some other possibilities too, but those are probably the two main ones. My perception is because you see these antibody responses, the other place that we've seen it in the last couple of weeks that I've talked about are in hospitals. And so when you look at studies on incarcerated people, you see 70%, in some places 80% of the dorms and these prisons are, that's how many percentage of the people that we find antibody results in. And so you simply wouldn't be finding so much antibody in all these people unless they had an acute infection that was generating these antibodies, or they've been exposed to the antigen and were generating these antibodies. And so that means that it's the T cells are not going to stop the spread. So that means if we're talking about the T cells impacting herd immunity, then that's not likely to be the case as far as I can predict right now. I might change my mind in the next few weeks, but I don't believe that it's going to change this herd immunity question. Again, what it could change is the severity of the disease. So again, people might have really, really mild symptoms or be asymptomatic, whereas before they might have had severe disease. And that's great news for those people. but I don't know that it's actually going to have an impact on herd immunity, because otherwise we wouldn't be seeing such high antibody responses in these various places that we're finding them.
So with this analysis, even if we look at, herd immunity of 50%, and then we take the ratio of just the people who are susceptible, in most places around the country, forget the outlier states where the outbreaks are happening right now, although we could look at them separately. I mean, what percentage? We're still at like maybe 5 to 10% infected, perhaps.
Oh yeah,
So we're still far off.
Hugely far off. Yeah, you're exactly right. In terms of, let me go back here for 1 second. I like this website. I come back to it a lot. This is projections. This is the one that I showed earlier showing machine learning. So this is total infected. So right now, the best estimate, I do trust this estimate, is probably around, 12 to 15% of the US population has probably been infected at this point. So we are not anywhere near where we need to be. You might hear some people in the news saying, oh, herd immunity can be achieved at 20%. And again, based on my analysis, that is simply, I don't believe that right now. Our best estimate is we're currently at 12 to 15%, and herd immunity is not going to get us where we need to go. Too many people's lives are at risk. There's no way to get so many people exposed without having millions of people die. And by millions, I mean, we were looking at 2 million is probably the best estimate early on, but it's easily at least 1 million people if we were to try to find natural herd immunity, and that would be extremely worrisome. Herd immunity should not be an option for us to be thinking about.
Okay, so herd immunity is off the table at this point.
Until the vaccines. Once the vaccines come, then that will be, I'm talking about natural herd immunity. Once the vaccines come in, then that could be a very rapid way for us to get herd immunity that's based on the vaccine response. So we have immune response from that.
Okay. So with herd immunity kind of being off the table for now, as schools across the country are looking towards reopening in the next few weeks or month from now, what is your stance on schools reopening, and what should schools be thinking about, and what should parents be thinking about?
Yeah, so I created, so Debbie, I think you had asked this question last week. We talked about this in depth on July 12th, so I'm not going to revisit that. The main questions that we looked at, I can go back a little earlier to the main questions we looked at, if I can find it without too much hassle. So, okay, I'm not going to, is this it? I think, no, this was the death delay. All right, I'm not going to go into too much detail. So if you go back to July 12th, you can find it there. There are basically like 6 or 7 questions that we were evaluating in terms of what the impact was on kids, how likely the kids were to infect it to other people, and questions like that. There were a couple of new things over the last week. So my assessment there was that the stakes are high. The stakes, because if the kids don't go back to school, then there could be real problems there. And if the kids do go back to school, there could also be problems. And so the key insight there was that we saw some outbreaks in Israel that were big. Now we've similarly seen outbreaks. This was the slide I just got. I can go back here briefly and just go back before I go back to the test that we're seeing right now. And so this is this. So a large South Korea study demonstrated that there was, that children younger than 10 could transmit to adults also. And so transmission is possible. In Israel, we did see outbreaks happen. And so it's definitely possible. But there are going to be schools reopening. I have two responses. One, the big thing that we're looking at in terms of schools are we don't want the school to contribute to a local outbreak. Well, guess what? In these parts of this country, where all these states have an ongoing big outbreak right now and are most at risk. In fact, I prefer the other one. This dashboard. This dashboard is better because this weights the ones that have an active outbreak more than the other things. The other dashboard I was just showing you also looks at how logistically capable their contact tracing is and stuff. This one looks simply at the outbreak. And every single state in red needs to, right now, I've been saying for weeks, they ought to be locking down until it's under control and then think about reopening schools. Because you can't even begin to think about a school causing an outbreak if Florida already has an outbreak. I mean, that's already, the whole point of not reopening would be to prevent the thing that they already have. So Florida, of these states in red, ought to be closing until it's fully under control. Because the problem is that we're going to be having this thing. So here's the US. You see that when we opened before, we had this long trail because we didn't lock down all the way. If we had literally just locked down the entire country for 2 weeks, we had all these, the checks that were sent from the government to bail people out when they lost their jobs. We should have taken full advantage of it and had a full shutdown for 2 months. Then we would have dropped the cases down to 0. The problem now is that you see this long, slow decline. That's probably what we're going to be seeing again here, where we're now at a new high level, and we're going to again have this low, slow decline, where it's just going to be a meat grinder, and lots of people are going to die as a result. And it's terrible. And so now when we're talking about kids going back to school, yeah, it's probably going to drive these numbers up a little bit more. And it's not just the kids that are the spreaders, it's the faculty that work at the school, the staff, and the parents who are mingling with each other more now that the kids are going back. Here's my big test. And my big test is this. This I saw was a Facebook meme. And so I'm sorry I didn't write it up closer. I hope you can see it. Okay, I'll read some of them out. These are really important questions. And so I would ask every single one of these questions to your school if it's about to reopen. And if your school doesn't have good answers for every single one of these questions, then your school is not prepared to reopen. So let me read off just a bunch of them. If a teacher tests positive for COVID-19, are they required to quarantine for 2 to 3 weeks? Is their sick leave covered and paid? So these are very logistical, tactical questions. If that teacher has 5 classes a day with 30 students each, do all 150 of those students need to stay home then and quarantine for 14 days? Do all 150 of those students now have to get tested? Who pays for those tests? Are they happening at the school? How are the parents being notified? Does everyone in each of these kids' families need to get tested as well? Who pays for that? What if someone who lives in the same house as a teacher tests positive? Does that teacher now need to take 14 days off work to quarantine? Is that time covered? Is it paid? All of these questions are questions that are going to happen. Literally every school that reopens is going to have to answer every one of these questions. And if they don't have these questions answered before they reopen, they are not ready to reopen. And that's as simple as that. Forget about anything else. I like these questions because they're very specific. All right, so I'm not going to talk much more about that. They're here. You can see them on the video. I'm putting them on YouTube after, and it's important. But again, the whole question of whether schools should reopen assumes that the outbreak is not going on, and that the background caseload is very low. But in much of the country, it's not the case. The outbreak is massive right now, more than in most of the world, except for maybe South America where it's wintertime, and some other countries, a bunch of small number of other countries. And so anyway, these are the key questions. I see this as the test. If your school can quickly answer these questions, and if it's all transparent, so every teacher, every parent, every staff member knows immediately where to go because it's been published either on a website or there's some sort of operating procedures that have been published, then the school is ready to reopen and all is good. If they can't immediately answer these questions, they are not ready to reopen. And that's it. Easy answer to your question, right?
Sure. No, but these are good questions, and there's no easy answer. Unfortunately, you're right. There are a lot of problems if schools don't open for the families involved, and certainly lots of problems if they do. So we will certainly be hearing more and seeing more over the next couple weeks for sure. So since we've
sorry to interrupt you for 1 second. There's one other thing I mentioned last week that I want to, or July 12th, that I want to bring up again. And that's before I go on, this question of elementary schools versus high schools versus colleges. And so there is a major difference. And one thing that we found is there's a very huge difference in kids who are prepubescent versus those that have puberty. And the prepubescent kids don't seem to have a lot of ACE2 receptors, and there's different immunological responses. They, in many ways, are a lot safer and are much lower risk than kids at high school level or kids who are going to college. Kids who are in college have way more high risk behaviors, and so that's a very different story even than kids in high school. Kids in high school live with their parents and put their household potentially at risk, whereas kids in college are putting the staff, the faculty, and other students at risk there. And so they're very, very different types of questions. And so a lot of colleges have very developed policies now that are in place. If you go back to July 12th, I put some websites up there that tries to track all the different policies across the states and across the colleges to try to describe this, both in the US and abroad, to try to show the variation so you can see how your school might compare to other schools. But that's it. There are three different questions. Should elementary schools reopen? Should high schools reopen? And should colleges reopen? Don't all necessarily have the same answer.
Thanks for clarifying that. That's a very interesting and important distinction, that's for sure. So since we've been talking about a bunch of good news during today's session, do I dare ask, and should we maybe wrap up about Sweden? Is this good news? I hope this continues the good news trend.
Sweden is actually a good news. So you'll notice before Sweden was bad. So if we're looking at this website that I sometimes go to, whether a green means that that a country's doing well, yellow means that they're nearly there, and red means that they need action. So if you look at the reds for a little while, we didn't talk about this earlier. South America, I didn't mention, I try to keep on mentioning it. In the Southern Hemisphere, it's currently winter. And so that will be our future, because we know that the R value increases in the winter because people spend more time inside. It overlaps with flu, and so flu season coincides. So people can get COVID and flu at the same time. And so then it's not just a coughing disease, but then with flu and other cold symptoms, you can actually sneeze. And so now COVID can be a sneezing disease, and it would just increase the R value. And so this is because of reasons like that, we do expect that winter is going to have increased spread. The numbers, it's going to be much harder to contain at that point. And indeed, if you look at Argentina, you look at Australia, you look at Brazil is over here, you look at other southern countries, they are really struggling. Their numbers are continuing to go up very rapidly. Chile is getting it somewhat under control. I haven't been following that very well. But if we go back to the Sweden question, Sweden, if you recall, they were unique because they did not have a formal shutdown like the rest of Europe did and the rest of much of the world did. Much of the rest of the world, like if you recall, Germany and France, they had this major outbreak. They shut it down, and unlike the United States, they got it down to a point that there were few enough cases, that simply by testing and tracing alone, and then with their policies of masks and physical distancing, they could get the caseload low. So for instance, Germany has less than 1,000 new cases a day compared to our number, which was we're averaging around 60,000 new cases a day. Germany is a smaller country, but their numbers are far, far lower. They're doing well. Much of Europe is doing well. When you look at France and you look at Ireland and you look at Italy and you look at Norway, Europe is tending to do quite well. Sweden was the exception. And so Sweden was going up, then they plateaued for a little while, then they were going far up, and now they've come way down. I'm not sure what's going on, but still, they did not have this exponential growth. Sweden didn't shut down their elementary schools. Their elementary schools stayed open during the school year. They did shut down their high schools, and they did shut down their colleges. They allowed the restaurants to stay open, and they allowed many businesses to stay open. They didn't require masks or anything like that, and yet their numbers didn't get out of control. And so Sweden, a lot of people have been asking, well, maybe the United States could be more like Sweden. And so when you look, I've been tracking newspaper clippings, like what's going on? What's the policy in Sweden? And what's going on is, let me just read some of these quotes. So Swedes in general have changed their behavior to a great extent during the pandemic. And the practice of social distancing as well as physical distancing has been widespread, says this one infectious disease expert in Sweden. During the months of March to early June, all shops were practically empty. So even though they were technically open, the country did not force them to shut down. They were practically empty. That is not what the United States experienced. Without the guidelines, people were out on the beach partying and they were not obeying anything. Here in Sweden, people stopped dining with friends. Families stopped seeing even their closest relatives. A lockdown could not have been more effective, they said. I mean, technically, it would have been slightly more effective because we just saw the difference here. So it wasn't perfect. You can see that it wasn't perfect. So the lockdown would have been more helpful to keep the numbers low over time, but it was not nearly as bad as it could have been. Another person said, the decline is likely to be a combination of measures taken by individuals, businesses, and a widespread information campaign launched by the government. Even without a stricter lockdown, many businesses allowed employees to work from home, and universities are offering distance courses to the students. So Sweden was not ever the laissez-faire example that we thought that it was. There, even without a lack of guidelines. In fact, early on in the epidemic, you might recall seeing this slide that I've shown previously. So this was showing the amount of cell phone travel. And so they were tracking where cell phones were, and then they could see how much people reduced their travel. They were able, this is a county level, each bubble represents a county, and the size of the bubble is the size of the county. They were comparing counties with stay-at-home orders to counties without stay-at-home orders. And certainly the counties with stay-at-home orders traveled far, far less. In fact, this was approximately, I think, like 85% order of magnitude less than normal. 0 would be normal. And yet, even counties without stay-at-home orders reduced their travel by around 65%. So we know that the guidelines are not perfect, first of all. It's not 100%, even though it was locked down. But we also know that even without any stay-at-home order, people dramatically changed their behavior. So this was a 65% reduction, and that's consistent with Sweden, that there was a huge reduction in Sweden just based on what they were doing. And so while Sweden didn't officially lock down, many in the country have described a lockdown feeling. It's eased some in the summer months, but in the summer they've maintained the physical distancing and the other things that we've discussed. So, and so that's what Sweden is. So again, Sweden's a very different country than the United States. And by that specifically, what I mean is that in the US, a lot of these states that are doing poorly now are, let me go to this one, or I can go to this one. A lot of the states that are doing poorly, it's because the people are not acting the same way that they were acting in Sweden. The American citizens were going out to the beach and partying and going to the bars. So just technically, just because a bar was open in Sweden doesn't mean that people were going. They were mostly empty. We just heard that quote saying from the infectious disease expert in Sweden. Whereas here, if you allowed the bars to open and just opened up every bar in the country and allow as many people to go in as they wanted, the spread would be out of control. The American citizens just are not as responsible as the Swedes are. And that's an unfortunate thing, but we need different policies here because the American citizens are not acting responsibly, and that's what you get. So I don't know. I mean, I don't know that it was good news or bad news. It is what it is. But clearly, it's good news for Sweden. They've definitely gotten their numbers down from what they were a few weeks ago, even.
Well, I'm happy for Sweden, and hopefully that can be a very important case study for those making decisions around the country as far as legislating morality to the extent that we can as a country. So with that, I thank you, Glenn, on behalf of our audience, both here and watching on YouTube after. You continue to shepherd us through this experience, and we are forever grateful. We truly are. So thank you.
The pleasure is all mine. Thank you, everyone, for joining and for watching on YouTube. Again, if you have any questions, please send them over. I'll try my best to answer them as well as I can. So have a great week, everybody.
Same place. See you next Sunday.
Sounds good. Bye-bye.
Bye.